maybe whoever is speaking didn't know like where to park. I drove all around, and a few were late because we're all running around because the parking for the public parking lot there, it's not working. So we couldn't put our credit card.
Yeah, well, we made arrangements we could park under the building. I sent out emails about it.
I thought it was just for that one meeting.
No, it's the whole year. Yeah.
Yeah, because it was the assumption that we had a different room change, that it was only that. No worries, it's not ready.
Oh yeah.
Yes,
How you doing?
I'm good.
I was in through the country.
The weather's changing.
What's your deer?
Yeah.
We're hiring
I just did it parking lot. Yeah. I have no idea if it's legal or not. I just did. I'll find out.
Where's the park?
I don't know. There's a building.
You wanted to co-write the vitamin C.
Call it construction.
Get the house.
It's going to be a long-term issue. For now it is. Once they finish the construction, I'm hoping it's not.
He must be constantly looking at the medical literature, the internet, and thinking about things. His brothers who want to keep searching.
It's insane right now. This area is totally transformed.
Who else?
No, it's very different.
All right. Well, other than ordering some lab reports today, I haven't done anything.
Did you have one part? Okay. How you been?
I'm good.
Good.
6:25 meeting here.
You away?
Yeah. No, it's funny.
Yeah. Extra hour?
Yeah, I tried to get to well, no, I mean, there's all the ones around this room.
That hat and jacket.
Probably done like an hour.
You must have a spare.
I have multiple.
You can leave it there if you want.
I'll keep it there. Thanks.
Now you're getting in any golf?
No.
No, you're not a really weather golfer.
Huh? No, I'm not a bad weather golfer. I'm just doing this.
Oh, no, I'm right.
Some of us have to study for our second course.
And one person did try to park where Hobby is about the gate. 5 years.
That's great.
What do you usually study?
Well, I probably the best thing is to contact them one day before and say, we have a conference.
Yeah, the life science thing. I might have studied
What I would do personally, what I did was I don't think I chose to do that. I went to TripAdvisor. I did something like
right now, they know I do. And it said on the things the area is okay. I have a friend in Houston that wrote it. They were here. Yeah, he didn't clear contaminated. You know, Houston. I wrote it, but I said, what's the theory like? So what I was going to do, I was going to contact him. Sometimes on these yeah, right. We have to wait a minute. But the allergy, I'll ask it on. They have a sign. They have one that's they have one leaving at 5:30. Yeah. Yeah, well, I like going to the clinic sessions, so that's how it's going to be. But you know, the other side, I don't like coming because of the sun.
I admire you.
It's good article on the NRCD for it. So I wonder what it's good. Why are they located? It's taken up with
But you know that Seattle
it's interesting where we look like this. So it's hard to know. Does it localize against my damage?
Uh-oh.
Tricky or something.
Maybe they should get back to you.
Yeah, we don't get back to it like we do in your gut. So it's provocative.
You know that testing IgG counts.
You put in your garden today for the winters. Mulching things that you have to mulch.
Okay, a couple of announcements before we get started. The word of the day is Northgate, whatever reason. And some confusion about parking. I didn't see, but anyway, the offer for parking is good for the whole year. Some people, I guess, interpreted because we were in the adjacent building, it was only good for last week. A problem, however, is there's a gate downstairs. It's supposed to open at 6:30, and it wasn't open this morning when one person tried to park. So we'll remind them the Monday before. If you can find street parking, still so much the better. Plus, it'll cost the division $3 every time somebody parks down there. But I didn't want anybody driving away and not coming because there's nowhere to park, and the street parking is becoming really difficult. Another announcement, we want to do the self-funded Sunday night dinner at the Academy. It was a big success last year, and I've sent out, I think twice now, or at least once, asking who's going to come. For the fellows, we'll pay for you and for your family and your kids, so whoever, just tell me how many, huh? Whatever, you can bring whoever you want. Well, not exactly whoever you want. But, so just give me a heads up because I want to start negotiating with a restaurant, like we did last year, try and get a restaurant to close the whole place just for a private party for us. So a lot of people have not responded. So a lot of you that are listening anywhere that you're listening. So this goes basically for anybody who feels they're affiliated with Seattle training program or the University of Washington, wherever you are in the U.S. right now, you're welcome to join us. And because pharma won't pay for it, there won't be any talk, at least by pharma. The other two announcements are up here on the board. Speak up if you're the speaker, so I don't have to remind you, and I don't have to get reminders from outside the room. And if you're going to unwrap your sandwich, do it now, not once the speaker starts talking. All right, so today's presentation, after all of that, is on celiac disease by Thao.
All right, as Lynn said, we're going to talk about celiac disease. I'll try to update you as much as I can. I have no disclosures. All right, celiac disease. It is a chronic immune-mediated enteropathy of the small intestine, and there's several factors that requires celiac disease. One is you have to eat dietary gluten, which is a prominent part of the Western diet, and you have to be genetically predisposed to it, and we'll talk more about that. But the prevalence is increasing throughout the world. In the U.S., the prevalence seems to be ranging around 1%. Some studies it ranges to 2%. And the biggest area where they think celiac will really show up is actually in India and China as their diet becomes more Western. But celiac requires the ingestion of gluten, which is a general term of proteins found in grains. And these are proteins found in grains that are storage proteins. And what characterizes them is that they have these long monomer chains of high prolamine polypeptides. So they have lots of glutamine, proline residues. And in wheat, the protein peptides are called gliadins, or they could be the glutamins peptides. The rice is seclin, and barley is hordein. But those are the ones in oat. Oat in general do not have these series that seem to be immunogenic as gluten found in the wheat, rye, barley grains. But this is the pathogenesis, the deduced pathogenesis of it so far. But the difference between people who are able to eat gluten without any immunogenicity to it versus those who are susceptible is that gluten itself in nearly everyone is, as mentioned, one of these monomers that are hard for the peptidases in the gastric mucosa, the pancreas peptidases, and at the mucociliary surface to break down because of these proline and glutamine chain. So it gets partially broken down, but in those who have a tendency to have a quote-unquote normal GI tract, they get broken down relatively well into absorbable amino acid level or insoluble peptide in which it's just excreted through the GI tract. In patients with gluten, these peptidases only does a partial proteolysis of these, and this partial protein, these what we call gliadin, actually affects the mucosal lining and actually enter the lamina propria of the duodenum. And this is when it starts triggering the inflammatory cascade. And the methods that they go through is both paracellular through the tight junction and transcellular. The transcellular pathway is not well defined, but interestingly, through the paracellular pathway, it looks like patients with celiac disease actually produces a paracrine protein called zonulin that increases the permeability for these reagents to pass through the tight junction more than normal controls. So with that, as these large, partially broken down peptides go in, called gliadin, what happens is it gets recognized by the tissue transglutaminase. And tissue transglutaminase is usually in its inactive state, doesn't trigger any inflammatory signaling. But when it sees these partially proteolytic gliadin, proteolyzed gliadin come in, it binds to it and it starts deaminating the glutamine monomers on this. And what used to be neutrally charged glutamine monomer becomes negatively charged glutamic acid. And that's when actually everything happens in the celiac patient. Because now there are these peptides, gliadin peptides, that are negative charged. What's interesting is, we'll talk in details more about it, is that if you have the genetic phenotype and HLA phenotype of HLA-DQ2 or DQ8, what happens is their binding site, of their MHC2 receptor for their antigen-presenting cell, the binding site of these characteristic genetic of DQ2 and DQ8 is actually highly positively charged. So these highly negatively charged gliadin peptides now get very attracted to these positively charged receptor. So consequently, it starts triggering the whole pathway of antigen-presenting cells with this. Now, there's several things that's happening at this time. By this time, the inflammatory cascade is already starting, because when tissue transglutaminase gets activated, it appears that it starts triggering another series of cascades that actually starts attracting cytotoxic T cells, and interferon gamma starts being released, as well as actually it appears to trigger the innate pathway of toll-like receptor 2 also. So there's some studies looking into that. Then, as it activates actually the antigen-presenting cell, now the whole adaptive pathway is being triggered also. At this time, more interferon gamma is being released, and the spike signaling of interferon gamma and tumor necrosis factor alpha actually triggers myofibroblasts to make some metalloproteinases, which induces a lot of the enterocytes destruction, the mucosal remodeling that's occurring, and the villus atrophy that occurs in the duodenum, and that's what causes the malabsorption presentation, the GI presentation of celiac disease. Now, as the adaptive pathway is continuing through the binding of these deaminated gliadin with PTG, that starts triggering the T helper cells to induce plasma cells. And this is where we see the antibodies that we measure in celiac disease, because the plasma cells starts making antibody both to the gliadin protein as well as to tissue transglutaminase protein. And because you see a high spike in both of them, the theory is because they're both still consistently covalently bonded in the antigen cell factor. And so the whole cascade occur, and that's the pathogenesis behind celiac disease thus far. So clinical manifestation of celiac disease, so you have the GI clinical manifestation as the upper GI tract is starting to be more affected. You have altered bowel habits, so diarrhea to constipation, abdominal pain, bloating, delayed gastric emptying, heartburn, and weight loss through malabsorption, often seen more rapidly in children. And then because of the malabsorption and because of general autoimmune association with celiac disease, there's also manifestation of fatigue, arthritis, joint pain, headache, mood swing. Children can present with short stature. Adults and children have iron deficiency, anemia, B12 deficiency, osteoporosis due to malabsorption of calcium and vitamin D, hepatitis. Those who have a celiac manifestation of dermatitis herpetiformis can occur, IgA nephropathy can occur, and then the peripheral neuropathy and cerebellar ataxia from the micronutrient absorption, such as B12. So,
Now, some of those are obviously explained just by malabsorption.
right.
How about, go back for just a second, how does that immunopathogenesis that you talked us through explain some of those other diseases? How do people, why do they get dermatitis herpetiformis or neuropathy or nephropathy?
The neuropathy and nephropathy isn't well explained, but some data that shows that the nephropathy occurs because the DQ2 patient also have other autoimmune manifestations. So, like for example, a lot of these patients with these type of HLA also have type 1 diabetes. So a lot of them have Sjogren's, a lot of them have lupus.
So the same events just occur in other organs because they all express the same HLA type.
Exactly. It's an association with HLA type and not so much a direct association with the intrinsic duodenal disease itself. So talking about dermatitis herpetiformis, one of the issues with this is there doesn't seem to be a clear explanation of the exact mechanism of association between the GI tract manifestation and the skin manifestation. But they definitely see it as an association, but it's defined as intensely pruritic papules on the extensor surface of your elbows and knees, but buttocks and scalp occurs also. It actually has a later onset of manifestation in third and fourth decades of life in general. There's a higher male to female ratio for dermatitis herpetiformis, which is interesting because in celiac disease, there seems to be a higher prevalence, in female to male. Female compared to male. Now, what's interesting about this is of the patients who have all the serology of celiac disease, but who have positive IgA deposition that's consistent with dermatitis herpetiformis, less than 10% of the patients seems to have symptoms of malabsorption versus vice versa, where patient with celiac and no DH have 50 to 60% have symptoms of GI malabsorption, but those with dermatitis don't. However, when they actually biopsy the duodenum, the small bowel of these patients, a good number of them actually have the histological abnormality of celiac disease, where 70% of them have villus atrophy, and that increased lymphocytosis of the epithelial cell on small bowel, which is an interesting presentation. But yeah, it's just a picture of the vesicular changes on the extensor surface of dermatitis herpetiformis, and this is the classic IgA deposition you see on indirect immunofluorescence of skin biopsy. So at-risk population, not only do you have the presentation that puts you at high suspicion, there's an at-risk population, and a good number of it is genetic. It's not just HLA. HLA is the defined genetic, but there's definitely more genetic that's being worked out. There's a monozygotic twin concordance rate of 75%. First relatives often have a 10 to 15% prevalence. Trisomy syndrome is often associated at about 4 to 5%, depending on the trisomy syndrome, to celiac disease. And the patients with selective IgA deficiency often have a 10 to 20% higher risk of celiac disease. Autoimmune disease is also associated with celiac, and with ranging about 5 to 15% prevalence. So you see it with Hashimoto's thyroiditis, type 1 diabetes, lupus, Sjogren's, autoimmune liver disease. So we have patients with autoimmune disease and GI issues. It's definitely prudent to consider celiac disease in this patient. Nutritional deficiency is probably more of a sign for at-risk patient with unexplained iron deficiency, anemia, and those with young metabolic bone disease, signs of osteopenia, osteoporosis, and then those who are coming in with GI disorders, complaining of irritable bowel syndrome, those with elevated ALT, AST, that's unexplained, those with malabsorption, weight loss. And then female infertility and delayed menopause, definitely consider celiac as a potential back issue. So once you have your signs and symptoms suggesting celiac, once you denote the at-risk population, one of the first recommended things to do is obtain serology. And they've moved away from the whole anti-Gluten antibody because the sensitivity and specificity of that test, which was produced in the 1980s and 90s, are relatively low to the test that's available now. But for serology to take place, the patient has to be on a gluten diet for at least 1 month. The half-life of serum antibodies 30 to 60 days in general. So that's the recommendation of at least 1 month of a gluten diet before you measure this. If you measure it on a low gluten or gluten-free diet, then the sensitivity for all these serology tests plummets dramatically. So the first test that's often recommended, and it's part of most of the common testing you'll find out there, is IgA tissue transglutaminase serology. And this is often used in patient population greater than 2. It has a pretty high sensitivity of 97%, a specificity of 94%, and it's been proven through labs that TTG, tissue transglutaminase, as we spoke through the pathogenesis, is the major autoantigen in those patients with celiac disease. And the use of IgA tissue transglutaminase is used both in diagnosis, in following the course of the disease when they go on gluten-free diet. And it's also used, depending on the titer concentration, as a estimate, not a fully accurate, but as an estimate of the degree of villus atrophy in these patients. And as far as at this time, tissue transglutaminase is an ELISA test. It's pretty sensitive. There's also development of point-of-service tests for TTG to be done in outpatient clinic, but the sensitivity and specificity of that has to be sort of measured and compared to the laboratory right now. And the other test that's available is IgA to the endomysial antigen. And this is really just extracellular tissue transglutaminase and the antibody against this. And the reason it is called endomysial antigen is the way this test is done is it actually is looking for antibody binding, and the product they use is actually monkey esophagus. And the binding of our IgA endomysial antigen binds to endomysial component of the monkey esophagus. And this test was produced, it has a really high sensitivity, but it has also an extremely high specificity rate. The problem is it's technically difficult. It's indirect immunofluorescent. It requires monkey esophagus, or actually there's studies looking at the use of human umbilicus for this. And so it's a costly study, and it's starting to ride backward. But the interesting thing about when you use endomysial antigen is that it's important to note that this level, though it has a high sensitivity specificity, can actually fluctuate severely in those with type 1 diabetes, depending on their insulin level, and in patients with viral infection. So the current condition they're in should be noted. And finally, there's also the use of the IgG serology testing to the antibody. And with the IgG, it's mainly used in the setting for those patients with IgA deficiency, and also for children less than 2 years old. The IgG testing currently available is considered more sensitive than the IgA to TGG and endomysial antibody. So for the recommended, it's IgG to the deaminated gliadin peptide, so IgG to DGP. It has a pretty decent sensitivity, greater than 5%, though it is considered a little less specific than IgG to transglutaminase. And vice versa. The use of transglutaminase, the sensitivity goes down, but the specificity gets higher. And so, looking at the different laboratory tests out there, they usually combine both IgG to DGP and DGG. And the problem with serology, aside from the need for a gluten diet, is that there are tendency for false positive serologies whenever there's an enteric GI infection in patients with congestive heart failure, chronic liver disease, or hypogammaglobulinemia. There's also a tendency for false negative serology, of course, in a gluten-free diet or gluten-low diet, in those with that's less than 2 and IgA deficiency. Now, of note, there is a prevalence rate of seronegative celiac disease in 6 to 22% of the population. So they would have all the signs and symptoms of malabsorption, and when you look at the biopsy, they have all the classic presentation of the villus atrophy. And what happens is, for these patients, despite the negative serology, if you put them on a gluten-free diet, the mucous membrane actually improves and heals over time. So,
can you get dermatitis herpetiformis if you're IgA deficient?
That's a good question.
In other words, because you can see the IgA, or is that just a marker?
Yeah, that is a marker.
The seronegative rate seems to conflict with the sensitivities you just gave us. I mean, are these just different studies, or?
Yeah, these are different studies. Yeah, I could not. Yeah.
Because it changes a lot how you might practice.
Exactly.
So I could say there's a quarter rate of seronegative.
Yeah, and that's why the huge range out there. Yeah. So
that raises the issue. I don't know if you're going to get to it, about all the people who think they have celiac syndrome or whatever the heck that's supposed to be. It's not classic celiac disease.
Right.
Are you going to get to that subject?
Yeah, I'll get to that subject in general. Well, I figure we'll discuss it at the end. So. All right, so there's serology. So there's symptoms, and then there's serology, and then the classic is actually considered gold standard is the small bowel mucosal biopsy. 4 to 6 samples in second, third part of the duodenum is recommended, and 2 samples from the bulb region, mainly because the abnormality is patchy in this disease. So one of the first signs is intraepithelial lymphocytosis, so more than 25 lymphocytes for every 100 enterocytes is a mark of increased epithelial lymphocytosis. There's evidence of crypt hyperplasia, and then there's villus atrophy of varying degrees. Let's see. Here's a picture of the histological features of celiac disease. Section 1 is just to show evidence of increased lymphocytosis, intraepithelial lymphocytosis, and you can see it here also. And then C is a demonstration of crypt hyperplasia, and D, E, and F is where you really see the villus atrophy at worsening extent. Now you can see the increased crypt depth, but then the villi are just starting to blunt out. You can see that, the blunting, and now literally pretty denuded atrophic surface right there. So with the biopsy, that's pretty much what you're looking for, but the biopsy though is not specific. So one of the things is you can see a lot of lymphocytosis in the epithelial with normal villus architecture in common variable immunodeficiency, glomerulonephritis, IgA deficiency, even though and then you can also see it in patients with duodenal lymphocytosis, enteritis, T-cell. A lot of infection can give this picture, and especially H. pylori infection, bacterial overgrowth, giardias. Medication can also cause lymphocytosis from NSAID to mycophenolate, And then, to make it even more confusing, a lot of the autoimmune presentations, such as Graves and Hashimoto without celiac, can also show lymphocytosis. So, you can see villus atrophy with or without lymphocytosis of the epithelium, again, in a lot of autoimmune disease, from Sjogren's to lupus to rheumatoid arthritis to even type 1 diabetes, which is a disease often associated with celiac. You see it in TB and tropical sprue for infection. You can see it in our patient with eosinophilic gastroenteritis and those patients with radiation enteritis. One of the other things you can do, aside from doing serology and a biopsy, is actually look at the HLA. So this genetic markers, these haplotypes of HLA DQ2.5 and DQ8 have a negative predictive value of greater than 99% for celiac. So, a majority of the celiac patients have DQ2 haplotypes out there. And so when you have a patient who have a high suspicion for celiac disease, but the serology is borderline, the biopsy is borderline, you can really do HLA typing to rule out celiac disease. If they're negative, then they are highly unlikely, less than 0.7%. Likely to have celiac disease, and you'll search for other differential. Then there are patients who come to you and you can't really do serology because they place themselves on the gluten-free diet. What should you do to obtain definitive serology? One of the things is to do a gluten challenge, and the recommendation is currently, so there's several recommendations out there, but currently there seems to be a push to do about 3 grams of gluten per day for 2 weeks. Do serology, biopsy. If it's negative, you could increase it gradually to 10 grams of gluten per day and challenge again at 6 weeks. So, but there's numerous studies with ranges of how much gluten and how many weeks of challenge is necessary. The classic World Gastroenterology Organization recommendation was classically 10 grams of gluten per day for a 6-week period before you do serology and biopsy.
How much of that, how much in real food is 10 grams?
About 2 slices of bread to 3 slices of bread.
Now, have they looked at the opposite thing? In other words, patients who are seropositive and then they go, you need to be gluten-free. How long does it take for the serology to turn negative?
So that's a good question. That's the monitoring period with it. So it ranges quite a bit, and it's really interesting because a lot of the seronegative studies can show a range of patient days. Some of them, if you follow the IgA EMA of O, when they actually drop pretty rapidly, in which a few months, usually 2 to 3 months, the titers go down dramatically. But then a lot of people are just following the IgA to TTG now, and those serology can fluctuate, quite a bit despite a gluten-free diet. And it's always a big question for these studies is, are they truly on a gluten-free, non-contaminated diet? But yeah, so within a month or two, for most studies, they see some fluctuating changes in titers. But Yeah, so the gluten challenge is one of the classic, but the problem is a lot of people, once they're gluten-free and they have GI improvement for their malabsorption syndrome, do not tolerate a gluten diet and usually cannot have a prolonged participation in this. So there are current studies on actually cytokine release assays to do where they actually take the biopsy of the patient and do gluten challenge assays, and they're looking for cytokine marker release to see if it could be consistent with changes of celiac disease. And then there's also a look of intestinal fatty acid binding protein, and this is a protein that's released and studied in mesenteric ischemia to see a patient with mesenteric ischemia. But they found that celiac disease patient, when they have necrotic enterocytes, also have release of FAPP, and this could actually have a pretty good positive predictive value in 98% of children with celiac disease with positive serology. So, but those are studies that are currently ongoing, looks like. Anyway, we spoke a little bit about this, but the diagnostic criteria, the American College of Gastroenterology recommend that we obtain IgA, TTG, and then confirm it if it's positive with a duodenal biopsy. So for the pediatric population, they recommend similar pathway, but they do recommend for less than 2 the serology of IgG to TTG and deaminated gliadin instead. The European Pediatric Gastroenterology, Hepatology, Nutrition recommendation in 2012, in an attempt to see if they could pick out a population that may not need biopsy, recommended that if you have a high test probability and repeated, so every 2 to 3 months repeated IgA that has a TTG level that's greater than 10 times the upper limit of normal, and a positive immunosal antibody on a separate blood sample, and they have the characteristic HLA DQ2 and DQA, to them that based on the Muveric study, and if I have time I'll mention that, but based on the Muveric study, that has an extremely high positive predictive value for celiac disease, and consequently, if they have all those features, biopsy is not required in the pediatric population. Now, if they have a low test probability and a questionable serology, then one of the things is duodenal biopsy is recommended still, classically. And this is just a Muveric study. There's multiple iterations. This is the initiating retrospective, but there's multiple prospective study out there already. But they're looking at pediatric population, looking at the biopsy consistent with celiac disease, and how many of these patients have a high titer level of TTG. And they found that it has a pretty nice specificity, relatively low sensitivity, but because of the high titer, it has a really strong positive predictive value, as high as 100 in some study, 97% in this initial study. So, a gluten-free diet is recommended. Elimination of wheat, barley, and rye. There's data showing that most patients tolerate 20 to 15 milligrams of gluten per day. That's a very small amount. So, long-term adherence to a gluten-free diet, however, despite the initial comfort of a gluten-free diet, long-term adherence over years is only 17 to 5%. In the U.S., what's considered gluten-free? It's it's a voluntary labeling by the manufacturer, but gluten-free should be considered those ingredients that doesn't contain any gluten grains, or those that are not derived from any gluten-containing grains, or if it's derived from gluten-containing grain, it should be processed to remove to less than 20 milligrams per kilogram of gluten. And then very low gluten, you can have that label too, but it's 20 to 100 milligrams per kilogram, which is not actually effective for celiac disease patients. So,
what is spelt?
Spelt is gluten. Yeah. So you should avoid spelt.
Are there
That's a good question. Are there any other esoteric grains that have gluten that we don't consume much in North America?
No, not really.
So those 4 grains?
Yeah, those are the major. So non-responsive celiac disease account for 10 to 30% of the patients. So these are patients we put on gluten-free diet, but they have persistent symptoms, lab abnormality, histology abnormality. And majority of them from the studies, they're accounted for by just having exposure to gluten in their diet. They also could have symptoms due to pre-existing conditions despite the resolution of celiac disease at the duodenum. So they may have inflammatory bowel or colonic malignancy that has to be, or they actually have condition that actually the celiac disease actually induce, and lactose fructose intolerance can occur, bacterial overgrowth can occur, colitis can occur, exocrine insufficiency, and then a number, the data and statistic was all over from the study, but a number of the pediatric study shows that there was an increase in cow's milk protein sensitivity post-diagnosis of celiac disease. So. And then the more concerning are the refractory celiac disease. So they have persistent malabsorbed symptoms despite strict diet for greater than 12 months. What is concerning for them is you have to start considering is there chances of malignancy. So it's divided, the refractory population is divided into 2 groups. Type 1, when you do T-cell marker studies on them, they have normal CD3, CD8 expression, no evidence of T-cell monoclonality. So consequently, they have a good prognosis despite not responding to a gluten-free diet. And there have been trials of elemental diets in these patients, systemic steroids, or budesonide, zithron therapy on these patients. The more concerning is what's considered the refractory CD2, and these patients have T-cell abnormality changes, so loss of normal surface marker of their T-cell, rearrangement of their T-cell receptor chain, and consequently, they have a poor prognosis. They're often associated with transformation to enteropathy-associated T-cell lymphoma, which has a 5-year survival rate of 20%. And treatments is unclear, at this time. And then when you do histology on these patients, you also want to look for evidence of ulcerative jejunal-ileitis, and these are inflammatory ulceration found in histology that should raise a suspicion for lymphoma. So celiac disease patients have a risk of lymphoma for B-cell as well as small intestinal adenocarcinoma. And the ratio ranges with the more common diagnosis celiac, the more current monitoring celiac with associated GI lymphoma is about 1 in 4,000. So treatment, aside from gluten-free diet that's being studied out there, is actually the concept of degrading the gluten to absorbable non-immunogenic peptides before it gets to the duodenum. And there are several out there. The ALV003 is in phase 1 study, but they're actually made of 2 proteases. One is from a barley grain protease, and the other one is actually a bacteria. It's like Sphingomonas capsulatum bacteria, and so these are proteases they make, and they're able both in vitro and in vivo to break down gluten to non-immunogenic peptide. What's important about these, why ALV1 of the many glutenases out there's a lot that can break down gluten in vitro, but a lot of them don't work in vivo because a lot of these proteinases get broken down itself by the GI tract, by our peptidases and gastrin, so they're actually not active. And the whole goal of this is if you're going to eat gluten, you need to break it down before it hits your vulnerable duodenum. So if the protease you take with it doesn't, work by the time it gets to the duodenum. It's pointless. So right now there's study for this that seems to be hopeful. There's also another one that's actually from Aspergillus niger that's coming out, and that seems to be a workable glutenase out there. Then, as we mentioned, that patients with celiac disease have that leaky tight junction complex because of the release of zonulin. Lorazepam inhibits that zonulin, so it stops the translocation of the gliadin peptide through the tight junction. And they're in phase 2 studies. And the data is interesting. They have shown that a lot of these patients have improved histology following lorazepam therapy, but a lot of the patient doesn't actually have improved symptom improvement of their malabsorption, which is curious. But the problem with this is it only inhibits the paracrine kind of pathway, paracellular pathway. It doesn't inhibit the transcellular pathway, which is also involved in the celiac disease. And the final one out there in treatment future is vaccines. So they took various peptides from gliadin, protein, and seclin peptides. So these are ranges from the 15 to the 18 meter gliadin peptides, and these are the more immunogenic peptides. They put into these vaccines and inject it into patients like allergy immunotherapy, and to see if it works. And that's a big question, will it work? So it's in phase 1 study. It seems to actually induce regulatory T cell response as in allergy immunotherapy, but its effectiveness has to be worked out. So.
Are they doing those in the ones that have the HLA haplotype?
I'm sorry?
Are they doing the vaccines, in particularly with the HLA group, the 2.5 people?
Right. Strictly with that. So monitoring, the current recommendation for monitoring is actually repeat biopsy at 1 year to see if there's histological recovery. They follow serology and of the patient to see if they could predict mucosal recovery also. And then also monitoring is to overall health of this patient, respective malabsorption, check CDC, folate, B12, calcium, LFT, TSH. Make sure that they're also not showing any other autoimmune processes. Make sure you check for osteoporosis. And then, interestingly, there is an association with hypospasm in celiac disease. It doesn't correlate with the duration of their disease, and pneumococcus vaccine is currently recommended. That's it. My update on celiac.
There's a question from Chuck Jackson. Has gluten been measured in malted barley and beer?
I don't know.
Well, one thing I'd like you to discuss is all the people who don't really have this disease, but the epidemic of people who think they have something like it.
Yeah.
Before you do that, I'm just wondering, 1 or 2% of people, it's a lot of people, anybody speculated, is there any advantage to having this? Why in the world would we carry these genes to have this disease? And how, and associated with that, do other animals get this? Or is this unique to humans because we started eating this food? Anybody speculate on any of those things in a broader context? And why 2% of people are walking around with the genes for this in a common food stuff? You would think it had some biologic advantage or wouldn't persist.
Well, we keep them alive when they might have died evolutionarily.
So nobody speculated on a broader concept.
Yeah, no.
That's just sort of, when you get older, you think about it.
Can you tell us about support groups and patient education? Because a lot of patients ask about that.
Yeah, there's actually a number of support groups out there. It's very similar, it looks like, to FAD and things like that. So,
I had a patient who went to carry a card with her in 7 languages he would give to the waiter at the restaurant to make sure she didn't get food. And
Yeah, so speaking about the non-celiac gluten sensitivity, let's call it that, because there's many names when you look at these articles. These patients, they don't have serology, they don't have any of the histological changes. You know, what's interesting is they tend to self-diagnose. They on a gluten diet, they remove themselves off and place themselves on a gluten-free diet, and they have symptomatic improvement. You know, and the symptoms ranges and can be very similar to celiac disease patient, to very vague, such as foggy brain is often mentioned in these articles. What I found interesting is the later article in following these patients is that a good number of them, about 50% of them, have the HLA DQ2, DQ8 haplotype. So, half, you know, without the other propensity. So the question for me is, do they have some degree of symptom, some degree of low-grade inflammation that's really not measured by the tools available, and that they just don't have all the genetic abnormality that push them through to full onset celiac disease with the current known immunopathogenesis? Because the HLA is just a feature, that's often seen, but there must be some abnormality in certain patients with mucosal permeability out there also.
Well, from your readings, though, I mean, well, I'm not sure it was just lay people made up this diagnosis themselves, or did anybody in the field actually think this is a credible disease that's not true celiac disease, but is a medical diagnosis?
Right.
What do you think?
What it looks like from the current, just journal articles between 2013 and now, is that they're trying to see if they could define them better. I mean, that's a problem with them is this something that is a diet trend? That's always been a question. Or if this is something that the populace, because of the knowledge of celiac disease, is self-diagnosing and bundling themselves into a subpopulation. Yeah, but the problem is they don't have any good study marker to define this population at this time, and that's what they're doing. They're trying to see if they could define it out there. And there's several articles, but they're so vague. I mean, there's nothing to really concretely say that these patients actually pull away from just psychosomatic patients. So
where does the HLA haplotype track in different populations, like Europeans versus?
NR.
Are there certain places that have higher distribution populations?
It looks like a lot of it is actually where the studies are made. So, like, a lot of the studies are based on Scandinavian studies and U.S. studies, mainly because there's a big HLA type 1 diabetes screening study there called the TEDdy study. I think we have it in Washington also, where they really do follow just HLA haplotype and autoimmune disease. But there are population groupings out there for these studies, and UK, Sweden, Germany are big sites of studies. The U.S. have several sites of studies in Georgia, here, Colorado. And so a lot of the data comes from that population. The question is, where is HLA phenotype DQ2 is elsewhere in the world, and the distribution? I couldn't find good articles that has more of that worldwide map studies for it. But it looks like from the distribution of studies in the two, Western Europe as well as the U.S., it doesn't seem to be associated with any ethnic group, out there.
And then you would also think with the structural changes, you'd have big alteration in the microbiome. What sort of studies have been done there with alterations and effects on the disease or symptoms?
For the microbiomes, yes. I mean, I guess, are you asking for, was there any definitive studies on the...
Yeah, what kind of alterations have they shown, or could that be another therapeutic approach, to reintroduction of bacteria that have these peptide,
Yeah.
proteins?
So they talked about specific and various bacteria, funguses out there that can contribute to the production of peptidases to break down the gluten. But I did not find any strong article looking for specific microbiome that's lacking in celiac disease or prominent in celiac patient that may be a majority contributing factor to the inability to break down these gluten, and therefore contributing to disease. It's just, I'll probably have to search deeper for that, but there's no apparent aha organisms out there that says, these are the ones that's missing from celiac disease. There are the theories that it is a contributing factor.
Has anybody commented, it's a little bit like the issue with eosinophilic gastroenteritis, or esophagitis, rather, eosinophilic, a disease that didn't exist, and then the controversy, did it always exist and we didn't know it, or is it actually on the increase? Because clearly this disease over the last number of decades is on the increase.
Yeah.
The question is that real, or do we just now know how to recognize it and diagnose it, or has humankind changed?
Right.
Anybody comment on that?
Yeah, there's a lot of commentary on that. So the celiac has been described in the medical community, it seems like, since the 1950s. So it's been recognized for a very long time in population with enteritis out there, and that removing gluten did improve a lot of these patients in the past, but it wasn't really pathologically defined until there is a increased prevalence of it, and there is a marked increase prevalence of celiac disease, and that's always been the big question. Is it just more recognized? But I think there's been several Ireland studies, because with their social medicine, they could kind of follow through these patients more so. But there's been a noted increased symptom complaint of malabsorption over time, and which correlated with the increase in celiac diagnosis. So it's something that has been recognized, but it's probably increased mainly because of probably environmental changes out there, the food processing of gluten. But those are all hypotheses that are out there right now. So.
And there is a body of literature suggesting that autoimmunity in general has paralleled the increase in allergies, interestingly enough.
Exactly.
Maybe not double like allergies over the last 30 years, but
there's a parallel.
should wonder what we're doing with the key regulatory zone.
Any other
Thank you. Now, remember, we don't have a session next week. The Tuesday of next week is the UW holiday. You guys are lucky.
Government interview.
They're out there. I just don't think we're seeing them. Frankly, it's just one. Yeah, I think that the family practitioners and it's got that. They send them to us, and it's like we don't know what otherwise, primary diagnosis of the GI.
And this is, it's just like,
I think that's think what's challenging for us seems like that you could bypass the stomach by changing that flora, giving some aspergillus niger. How about for
Exactly. You asked the question.
Can you write?
Okay, thank you.
A little crazy.
Bacteria would be happy too.
Yeah.
I think they could handle a couple times.
Here's the number.
Yeah.
It is right there.
Oh, no, no, this, I
Oh.
parked at the, I don't know where this is.
Oh, did you park underneath?
No,
Down.
different one.
You parked in another lot?
Yeah.
There I can't help you.
Yeah, that's too bad because when I came in at like 5 or 7,
Yes.
yeah,
I'm wondering if
yeah, 'cause
so I'm wondering that.
Oh, Trixie.
Yeah, I
How many are there?
Well, nice
7.
review. So, who was supposed to do it? Like security guard?
Someone's supposed to open that gate by 6:30. She, because Nick tried to park there and he couldn't get in.
Yeah, I could. Well, that was. I realized that when I got here at 5 to 7, it was down. So.